Right, okay, so this next talk is called Medicines for the Heart. So what we're going to do here is cover the general, usual medications that the doctors will give you after a heart condition. Okay? I'm going to shut that because we'll get small children arriving from the crash of the light. Hopefully they can edit out me disappearing. Alright, so the information we're going to cover about medications is intentionally general. So we're going to generalise a lot about what you may find and what it won't be specific, to you. If you do think, as a result of something you've heard today, that perhaps that side effect, you're getting that, and perhaps what you need to do is stop that tablet, please don't just do that. Please go home and make an appointment with your GP to have a chat about it. It's not a good idea to start fiddling around, reducing your dose, increasing your dose willy-nilly without letting anybody know what you're up to. Okay, so obviously make a note of it and follow it up with your GP, but please don't just suddenly decide to stop taking any of your pills. Okay, so we're going to talk about the big four groups of tablets that there are. The first one is the anticoagulants, or the blood-thinning drugs, the most common one being aspirin. Before we talk about aspirin specifically, we're just going to talk a little bit about platelets, because aspirin is an anti-platelet drug, so it helps if you know what a platelet is in the first place. So a platelet is one of the blood cells in the bloodstream, and its job is to help your blood to clot. So if you cut yourself, what happens is that the platelets come to that area where you've cut yourself, and they all clump together and stick together to form a mesh, which is what then ends up becoming a scab to heal over that cut. And they also release chemicals in that little area there, which make the blood around it become more sticky to help make everything stick and clot together to make a scab. So if you've got a cut on your hand, that's quite useful, and we want that to happen. But unfortunately, it can also mean that platelets can go around causing clots and stuff in places that we don't want them. So the idea with the anti-platelet drugs, and the most common one that we've all heard of is aspirin, is that they reduce risk of further heart attacks by reducing the chance that a clot will form somewhere in one of the arteries, which can then go and get lodged in a narrowed artery around the heart. So it can also be given to patients who have angina to try and again reduce that chance that they get a clot forming that might go on to cause a heart attack. And patients who've had stents fitted will probably be on aspirin as well. We'll talk about the other anticoagulant drug that you'll also be on in a moment. It's useful to know that there are two different medication doses of aspirin that are available over the counter. So if you are buying yours over the counter and not on prescription, which most people do because they're much cheaper that way, you are able to get a 75 milligram dose and a 300 milligram dose. So it's just a note to say it's the 75 milligram dose that you should be buying. That's the one that we want you to be taking every day, not the 300 one. And if you remember nothing else at all from today's talk, remember that aspirin must be taken with or after food. You don't want you taking it on an empty tummy. Okay, and that is because aspirin can irritate the lining of the tummy and then go on to cause indigestion and possibly an ulcer. So it's very important that you don't take it on an empty tummy, and also always take it with or after food. Is everybody doing that? Yes. In words, yeah. There are also dispersible versions of aspirin available. So these are ones that you can kind of drop into a little bit of water and dissolve it and then take it in. If you wish to, you can do that. We're not particularly saying everyone should have dispersible. It's a personal choice thing. Usually most people find they've got several other pills they've got to take as well, and they're not dispersible, so it doesn't make a lot of difference to them to just have one that is. But you can take a dispersible version of it if you wish. In terms of side effects then, the side effects are related to the fact that it's stopping blood clotting. So indigestion, oh hang on, let's come back to indigestion. Sorry, it's changed the slide order. So side effects can include indigestion, which we've talked about, from the lining of the tummy being irritated, which can then go on to cause a stomach ulcer. Some of you may find that you've also been put on another tablet, which is coming on the next slide too, to try and protect the lining of the tummy as well. So some people, even though they take aspirin with or after food, will still find they get a bit of indigestion. And if you do, you might get put on a tablet to try and help protect the lining of the tummy, to try and help with that. And the most common side effect that people report is the bleeding or the bruising. Okay, so if you're just on aspirin, you might not have noticed this, that you come up in lots of little bruises, little purple bruises everywhere, and you don't even remember knocking yourself or bagging yourself, but there it is, a great big bruise on your arm or your leg or what have you, that takes a little while to disperse. It's even more likely to happen if you're on another blood thinning drug as well, which some of you will be. So if you're on clopidogrel as well, or ticagrelor as well, in conjunction with the aspirin, then you've got a double whammy effect there, so you're twice as likely then to notice this bleeding and bruising. So when you're brushing your teeth in the morning, you might find your gums are bleeding a little bit as well. If you do cut yourself, you'll find it bleeds for quite a while before it stops, and that's because you're on the blood thinning drugs, which have kind of reduced the body's ability to clot quite so quickly. All right. Again, she's just got a point here to mention that there are, if you're buying them over the counter, there is an enteric-coated version of aspirin, which is obviously sold to try and persuade you to buy that because it's more likely to protect the tummy lining. But she doesn't particularly recommend that over normal aspirin. It doesn't seem to have any particular benefit over normal aspirin, and it's usually a little bit more expensive as well. So don't be sold on the enteric-coated version being particularly beneficial for your tummy lining. Don't worry about that. Other thing to mention is other anti-inflammatory drugs. So aspirin is in a group of tablets which have an anti-inflammatory action. So that's why they also appear in some cold and flu remedies as well. So if you look at the back of the packet, if you buy a cold or flu remedy, it might well have aspirin in it because of that, because it has an anti-inflammatory and a sort of pain-killing action. So it's important that you don't use other anti-inflammatory tablets on a regular basis if you are taking aspirin. So other anti-inflammatories are things like ibuprofen or Voltarol, sometimes people call it, Nurofen, Cuprofen, anything that's an anti-inflammatory, because if you take those regularly, as well as the aspirin, it can reduce the effectiveness of the aspirin. Okay, so what her advice normally is if you have an injury, let's say you twisted your ankle or something, and you just wanted to take some ibuprofen for a couple of days to sort of see you over the worst of that injury, you can do that on a short-term basis. But if you do, she recommends that you take the aspirin first in the morning and then give it a good half hour or so before you then take your anti-inflammatory. So that allows time for the aspirin to get into the system and to bind with the cells that it needs to bind with in the body before you then introduce the ibuprofen. And then by doing that, you don't reduce the effectiveness of the aspirin.
Presumably that includes naproxen, does it?
Yes. Yeah. Okay, so in general, we don't want people regularly taking anti-inflammatories alongside aspirin, but for short periods of time to get you over an exacerbation or an injury or something like that, then it's fine, but always take the aspirin first and wait a good half hour or so before taking your anti-inflammatories. And again, just to mention, I don't think I've ever met anybody that's in this category, but apparently 1 in 20 patients who take aspirin may find that if they are asthmatic, it might increase the amount of wheeziness they have. Doesn't mean it will, it just says it might. So it's just something to be aware of if you are asthmatic and you get started on aspirin. If you find that you are suddenly a lot more wheezy, it could be that you're one of the 1 in 20 that don't get on with aspirin because of that reason. All right? So alongside this, and very similar to this, are clopidogrel and ticagrelor. So some of you may be on clopidogrel, some of you may be on ticagrelor. Nobody should be on both of these, so one or the other, okay? It can be used on its own, but more commonly we see it in addition to aspirin, and often after a stent is fitted. But it can be used in patients who haven't had a stent fitted as well. So patients with angina might be given it, or some people that are allergic to aspirin might be on clopidogrel or ticagrelor for life instead of aspirin. And it's usually given for a limited period. It says sort of 1 month to 1 year here. It's more often 1 year that you're on it for. Occasionally they might say 6 months, but it's more often 1 year. We don't often see people that are only taking it for a month. So if you're on one of these tablets, hopefully you were given a card at some stage. It looks a bit like that. Has anybody got one of them? Yes? If you haven't got one, they're on the table, and the idea of that is that you write down the day that you start that, so that you remember when the year has come round to stop that. Okay, because it becomes such a part of your sort of regular routine. If you don't remember or the GP doesn't remember, you might find you just carry on taking it forever. So it's a good idea to make a mental note of it, either on the card or on your calendar or whatever, so that a year after you start it, it can be stopped. And then you should find that that bruising that we were talking about with the bleeding problems should get better. It might not go away completely, but it'll be better than it was when you were on 2 blood thinning drugs. So it should get a little bit easier for you. Same side effects with these as with aspirin that we've already talked about. Right. And these are the tablets that I was mentioning that you may be taking to help protect the lining of the tummy because of the aspirin. So lansoprazole, omeprazole, there are others, they basically end in zol, yes. And they're given specifically to protect the stomach lining. So some patients start these tablets the same day they start aspirin to try and prevent any chance of getting indigestion. Some patients are just put on aspirin and not given one of these, and then see how you go, and if you get indigestion and you're taking it already with food, then you might get started on one of these. Okay, so some of you may have been taking these from day one with the aspirin, and that's just obviously what your doctor decided to do to try and prevent any risk of you getting any indigestion. Okay? Right. Yeah?
I mean, I've been taking all the medication for 2 years now, including the lansoprazole,
Yeah.
which in itself can actually make you feel a little bit. You never get to the point where you can say your stomach is now protected or it's got to be ongoing.
Well, if you're going to continue taking aspirin for the rest of your life, then the risk of you getting indigestion and ulcers is going to be there. But if you haven't had any indigestion symptoms in the last 2 years, it may be worth talking to your GP about whether to try and stop the lansoprazole and see how you go. Because you're going to keep taking the aspirin, but it may be that you're not one of the patients who gets indigestion with aspirin, in which case maybe you don't need the lansoprazole. But some people that have started on it and they feel fine on it just carry on taking it because they're not getting any problems with any of it, so why not? But it will be something to talk to your GP about rather than just decide yourself, yeah? Okay. So that was blood thinning drugs. That's the first group of drugs that we're mainly talking about today. The second group is the beta blockers, and the one that you're probably on is bisoprolol. So there are others available. They basically end in ol, but bisoprolol is by far and away the most common one used with heart patients because it tends to have more of its effect on the heart and less effect on the rest of the body. So there's a variety of reasons why you might have been put on a beta blocker. It's used for various reasons. It might have been given to you to help reduce your blood pressure, because that's one of the things that it does. It might have been given to you to try and prevent angina attacks, and one of the ways it does that is by helping to slow the heart rate down a bit, so that the heart isn't working quite as hard. Okay, so one of the main things that beta blockers does that you may notice is to slow the heart rate down. For that reason, it's also often given to control abnormal heart rhythms, particularly fast heart rhythms. So people who have atrial fibrillation, often that's a very fast heart rate problem, where the heart is going a little bit too fast. And so beta blockers can help slow that down and calm it down a bit. But the main reason that most of you will be taking it is because it has been found to reduce the risk of further heart attacks in the future. So it's all about prevention. So it may be that your blood pressure is fine and you don't get any angina and you haven't got any abnormal heart rhythms. But we still want you to take it because of the fact that we know it reduces the risk of heart problems in the future. So it's one of those preventative tablets. And it's also helpful for people who have heart failure, so people who have the heart muscle problem, where the heart muscle is not squeezing and pumping as strongly as it should do. It's also been found to be helpful in that category of patients as well. So it's doing quite a lot of things, that one little tablet. But alas, it also does have some side effects. This is another one, a bit like aspirin, that can sometimes cause people who have respiratory diseases like asthma or chronic obstructive airways disease, it can sometimes cause them to become a bit more wheezy. So if you have a respiratory problem, a problem with your breathing, and then it got a bit worse after you started the beta blockers, that might be worth something to chat to your GP about. Also, if you have diabetes, so if you have diabetes, beta blockers can make you a bit less sensitive to the warning signs of a hypo. So that is where the blood sugar drops too low and you need to do something about it to get your blood sugars back up again. Most diabetics at risk of having hypos can usually tell when their blood sugars are going to be getting a bit low because they get some signs and symptoms that make them feel a bit funny. And beta blockers will perhaps mask those signs and symptoms that would let you know that was happening. So if you do have diabetes and you've started on beta blockers, the advice is usually just to monitor it, maybe take your blood sugar a bit more often than you would have done to make sure that for you, your blood sugar control is still okay. So the main side effects that most of you will perhaps have experienced or will need to know about is tiredness or fatigue. Because the beta blockers are slowing the heart rate down, often people feel like they have been slowed down as well. So this feeling of sort of lethargy or tiredness. Does anybody get that?
Yeah.
Yes. So in theory, if you can stick with it, it's supposed to get better sometime around sort of 4 to 6 weeks. If you've already been on it 4 to 6 weeks and it's not really got better, then what you might need to do is go and chat to your GP about how much it's bothering you, how much it's affecting you, how much it's getting in the way of your life. But what you need to do is kind of weigh up the pros and cons, because we've talked about all the good things that beta blockers do. And if the expense for that is that it just makes you feel a bit tireder than you were, you may think, actually, on the balance, I'm going to stick with them. But actually, if it's making you feel really, really tired and awful and lethargic and you're falling asleep left, right and centre and you can't get on with normal daily living, then perhaps for you the balance was the other way around, that actually you're going to have to reduce the dose or stop it completely in conjunction with your GP. The other side effects that perhaps come, that you might notice, is dizziness, and that is related to the fact that it helps to reduce your blood pressure. So if your blood pressure goes a bit too low, it's possible that you might get dizzy spells when you're up and around and moving about. It's quite normal for patients to feel slightly lightheaded when they first stand up. If you've been sat for a long time, like you have today, and then you suddenly stand up, you might notice just sort of 5 or 10 seconds worth of slight swimminess, and then it clears, and then you're all right. That's kind of considered within the realm of sort of normal for a blood pressure tablet. But if it carries on when you're up and around and busy, moving around doing your normal everyday stuff, then perhaps your blood pressure might be going a little bit too low for you. So it'd be good to try and get some measurements done of that and try and see if it is. And then it may again be that we need to reduce the doses of the tablets to try and bring your blood pressure back up again. The other side effect that quite a lot of people mention is the cold hands and feet. Anybody get that? Yes. So one of the things that beta blockers do is sort of direct more blood towards the centre of the body and take some of that blood away from your hands and your feet. So that has a knock-on effect that your hands and your feet feel quite cold. You might not notice that over the kind of spring and summer months, but you'll definitely notice it when we get into the depth of winter. So it's not uncommon for people to need to wear sort of 2 or 3 pairs of socks at night to keep their feet warm, and extra thick woolly thermal gloves and what have you to keep your fingers warm. Again, it's one of those things that's kind of an accepted side effect of the beta blockers, but if it's really interfering with your sort of life and daily living, there's another conversation to be had with a GP about the pros and cons again. And beta blockers is also one of the tablets that can cause impotence in men. So again, the advice is to see whether within 4 to 6 months that actually improves, and if it doesn't, it's another conversation with the GP. Lots of conversations to be had with the GP there. So because of all the lovely, wonderful things we've said that beta blockers do, it's really important, I mean it is with all your tablets, but particularly with beta blockers, that you should not stop taking a beta blocker unless advised to do so by a doctor, because of all those things it's doing. If there is a discussion had about the fact that perhaps you need to come off of it, what should happen is that you gradually stop it. So they should reduce the dose right down gradually, and then you should start taking it every other day, and then come to a stop. You don't just sort of be on it one day and off it the next, because it's doing quite a lot of different things to the body, and to suddenly stop that, it might make you feel quite ill, or even bring on a heart attack. Any questions on beta blockers at all before I move on? So that's the second big group.
Can I make an observation?
An observation, yes.
When I've been taking them, it's changed my mood completely on my Sartrazol.
All right, changed your
It
mood.
took me on to 10 milligrams, and I was not a very nice person for a lot of time.
Oh, so what is it, sort of
So-
irritable and...
Oh yeah, just anything in the mind, in my head was...
Right,
But they reduced it back to 5 milligrams.
and then you're all right again? Yeah.
So I just wonder if that's anything that...
I wouldn't say it was a common side effect, but I mean, when you read the, if you ever read the huge little bit of paper that comes out of the box, there'll be some side effects which are common, and those are the ones that we kind of generally tend to go by and just talk to you about here. There will also be some that are less common and some that are very rare. That's not to say that you won't get them, because you might be that unlucky person in 1,000 or 1,000,000 or whatever it is. But it's not a common one, I don't think, the mood disturbance thing. Okay. So the third group that we're going to talk about are called ACE inhibitors. Okay, ACE inhibitors, and the name of the drug that you'll probably be on is ramipril, unless you've had a dry cough, in which case they might have switched it to a sartan, which is coming on the next slide. So ACE inhibitors, the ACE bit stands for angiotensin converting enzyme, which is all very exciting, but basically it's part of a system in your kidneys that controls your blood pressure, and it controls how much salt and water you keep or that you pee out in your wee. Okay? So this enzyme can make the kidneys either wee out a bit more water and a bit more salt, or keep a bit more salt, or keep a bit more water, depending on what we're doing with the blood pressure, and that's how it helps to manage your blood pressure. So by taking these tablets which inhibit the action of that enzyme, we end up helping to decrease the blood pressure, and again, lots of evidence now that it helps to reduce the risk of further heart attacks. And more recently they've also found that it can be used in heart failure patients to prevent it worsening as well. So what they've found is that if you leave a heart to its own devices, what tends to happen over the years is something called cardiac remodeling, which is where the heart is normally a nice rounded heart shape, but as the years go by it can remodel itself into sort of an inverted triangle like that, so it's kind of triangular and baggy at the bottom, and that's called cardiac remodeling. So the body is for some reason remodeling the shape of the heart in an unhelpful way that actually means the heart can't pump as well as it used to. And we found that ACE inhibitors actually stop that remodeling from happening. So again, that's one of the beneficial effects of being on ACE inhibitors. Even if your blood pressure is okay and you don't have heart failure, it's still a good idea to be on them if you can tolerate them, because of that extra risk reduction that you get from it. Okay. So the plan with ACE inhibitors is that they are usually started on a very low dose. So if it's ramipril, you probably get started on 1.25 milligrams or maybe 2.5 milligrams. So that's one of the lowest doses that we can do. And then what's supposed to happen is we send you off out home with those tablets, and what's supposed to happen is you go and see your GP, who then tries to gradually increase it. But before they can increase it, they need to check that your kidneys are behaving themselves okay. You remember we mentioned that this interferes with that system in the kidney where you're fiddling around with how many salts and how much water you're going to be weeing out in your wee. And so some patients can find that their kidney function can go a little bit strange on these. They don't tolerate them and their kidney function goes off. But you don't really get any symptoms of that, so what we have to do is a blood test and check your kidney function before we consider increasing the dose up to the next level. So if anybody has recently started on ramipril, then you should have made an appointment hopefully to see your GP within about 2 weeks or so. And one of the things that happens at that appointment should be a blood test to check that your kidney function is okay since starting these tablets. Is there anybody in that category? Has anybody started these recently? Has your GP seen you?
Yes, I've had one.
Done a blood test, yes, great, brilliant. So the plan is we check the kidney function, and if that's all tickety-boo, then the idea is we try to increase the dose up a little bit more. Because we've said all about the lovely beneficial effects that you get from these tablets, and we know that we get more beneficial effect the higher the dose that you're on. So we ideally want to try and nudge that dose up as much as we possibly can, as long as you feel okay on it. But because this one and the beta blockers, both of them reduce your blood pressure, sometimes we can't get you right up to the maximum dose because your blood pressure has gone so low that actually if we increase it any more, you'd be kind of on the floor, which obviously is no good. So we try to increase the dose up to as much as tolerated, yeah, which will be different for all of you. So that's something that should happen at GP land. But obviously you need to make an appointment to go and see them about that. Side effect wise, the main side effect for ramipril is a persistent dry cough. Did anybody get that? Yes? So again, if you can stick with it for 4 to 6 weeks, it might get better. So you can either stick with it for 4 to 6 weeks and see if it gets better, or if it's really bad, which it is in some patients, it keeps them awake at night, they can't get to sleep and all sorts, then you go and see your GP sooner than that, and they can change it to the next slide. We've got these ARB ones, which are a bit like ACE inhibitors, but they work slightly different and are less likely to cause a dry cough, but they do the same job. And the only other side effect really that's common with these is the dizziness, a bit like we said with the beta blockers, because it's reducing your blood pressure. If it goes down too low for you, then you may get some dizzy spells, particularly when you're up and around and moving around, which might mean that your blood pressure is going a bit too low. And then we might have to think again with the dose that you're on. So we need blood tests while we're increasing the dose, and then once a year at least, you should go in and see your GP surgery for a bit of an MOT, and one of the things they should check in your blood is your kidney function to make sure that your kidneys are behaving on those tablets long term. Right? So if you have the dry cough, they might well switch you to something ending in sartan. So candesartan, olmesartan, telmisartan, basically it ends in sartan. Does a very similar job as we've just talked about with ramipril, but it just works at a slightly different point in that kidney system, and for some reason therefore doesn't cause this dry cough. Okay? Any questions?
Yeah, you mentioned ramipril several times. Does that also affect the lisinopril?
This lisinopril, yes, lisinopril is in the same family. Okay, so that's the third bunch of tablets. So we've done blood thinners, we've done beta blockers, we've done ACE inhibitors. Now we're going to talk about statins, which is the fourth of the big four. Before we talk about statins, just a little chat about lipids, which is a posh word for fats in the blood. So there are different types of fats in the blood. There are triglycerides, there are low-density lipoproteins, and there are high-density lipoproteins. Now these two here, or well, all three really, can be divided again into good and bad cholesterols. Okay, so HDL is what we call good cholesterol. So it tends to go around the arteries searching for fat, and if it finds any, it brings it back to the liver to be got rid of. So we like HDL, we want to keep HDL and increase levels of HDL. Meanwhile, we want to reduce the bad cholesterol, so that's the LDL and the triglycerides, because those are the ones that tend to go and hang around in arteries and loll about and stick to the lining of the walls. So it follows really that we want to try and reduce the bad cholesterol whilst increasing the good cholesterol. And that's what statins do. So the aim of your cholesterol lowering treatment is to reduce your overall cholesterol, but particularly the bad cholesterol. So statins, and the one that most of you are going to be on is atorvastatin. That's the kind of one of choice nowadays. It used to be simvastatin, but atorvastatin is much better than simvastatin. So that's the one they're going for now. But there are others available. There's rosuvastatin and pravastatin as well. So there are different ones around. So statins will decrease your total cholesterol by at least 20%, so by at least a fifth, and your LDL, which is your bad cholesterol, by at least 30%. But they can cause stomach upsets, so sort of upset tummies, diarrhea, that sort of thing. Can cause headaches, and the one that gets all the bad press is the muscle aches. Yeah, so the muscle aches that go alongside statins, if you get them, will be sort of soreness, really painful soreness, usually in both sides as well. So it won't just be, oh, this shoulder is sore, it'll be both my shoulders are sore, or both my thighs are sore. Yeah? So it's really sore, painful to touch muscles. So a lot of people, because at the same time as this, their patients are starting to do a bit more exercise and go for a walk a bit more often, and you can get muscle aches because of that. So sometimes patients can kind of confuse the muscle aches that come with increasing your exercise with perhaps thinking it might be coming from the statins and wanting to go and see the GP to stop the statins. But it's a particular type of muscle ache with statins. It's very sore and it's usually both sides the same. So if you haven't just been for a walk, which can explain a sore leg or two sore legs, and you think it's down to the statins, obviously go and see your GP to talk about it. But most people do tolerate statins very well, and the muscle ache passes with time and is not too bad. This is a new thing she's added in. So vitamin D supplements can be advisable because vitamin D deficiency can magnify the muscle pain. So it means if you are low in your vitamin D, then it may be that you will more likely feel the muscle aches that the statins might cause. But you don't get those prescribed. So if you want to go and take vitamin D supplements, you have to go and buy them over the counter, unfortunately, at the moment. If you are having trouble with statins, either because of the tummy aches or the headaches or the muscle aches or whatever, it's better to try and reduce the dose rather than stop completely. Because obviously, even if you're still taking them but on a lower dose, you're still getting some of the preventative effects of them. But if you stop them completely, obviously you're not. There are also other things. People think it's all about cholesterol, but it's not. Statins have also been shown to have a sort of anti-inflammatory effect, a sort of beneficial effect on the heart muscle as well. So even if your cholesterol is quite good, they'll still put you on a statin because we know that long term your reduce of risk from a heart problem is lower if you're on a statin, and we know that they have other beneficial effects far and away aside from the fact that they lower your cholesterol. Any questions on that?
No problem in taking them with aspirin.
Any problem taking them with aspirin?
Well, it's an anti-inflammatory, you say.
Oh, it's not in the same style of drug
Okay.
though. It's not. It doesn't work in the same way. No.
All right.
This is an anti-inflammatory effect on the heart muscle itself that it seems to have, which they're kind of finding out all the time from their research
Right.
how it works.
Excuse me.
Yes.
If you tend to have any problem with sciatica occurring from time to time,
Yeah.
does this have any effect on that?
Not really, no, because the sciatica will be coming from some sort of musculoskeletal problem that you've got in your back or the nerves in your back,
Right.
which will come and go depending on what you've been up to
Yeah.
and stuff.
Yeah.
The fact that the statins are there is not going to have
Right.
a lot of effect
Okay.
on that. We're just going to mention a little bit about grapefruit and statins, because if you do read your little pamphlet that comes in the box, it talks about avoiding grapefruit juice. So grapefruit juice and grapefruit, to a certain extent, contain various substances that make your liver break down statins and other tablets more slowly. So the idea is that it will take longer for your liver to break down and get rid of the waste products of the tablets that you're taking if grapefruit juice is present, because there's this funny enzyme that seems to be concentrated in grapefruit juice, which interferes with the way the liver breaks down the tablets. So the advice is to avoid grapefruit, but it's really grapefruit juice that is the problem. A fresh grapefruit does not have the same concentration of this enzyme as grapefruit juice does. Okay? So if you want to have the occasional fresh grapefruit for your breakfast or what have you, then that's not an issue. It's drinking cartons of grapefruit juice or juicing down grapefruit juice that is more of an issue. Right?
Does that just stop the statins working so well?
It doesn't stop the statins working, no, but it makes it more likely that you get the side effects, like the muscle aches and the diarrhea and what have you, because it means that when you take your statin, instead of the body being able to process it through and get rid of the waste products of it in a 24-hour period, it will slow that down, and it means that the level of statins in your blood will build and climb, and that then makes it more likely that you get more side effects.
Grapefruit,
It's not going to make any difference.
once every couple of months or something.
It's not going to make any difference, no.
I was
But
told
obviously
that
there are.
taking grapefruit was dangerous, you know,
No,
dangerous to your
no.
life. Sort of thing.
No, it's not dangerous. The worst that can happen, even if you decided, mad that you were, to drink a litre of grapefruit juice every day,
It's just temporary.
what will happen is you will get the side effects of the statins a lot greater than you would have done otherwise. But it might be worth it for you. If you really love grapefruit juice, you might think, hey, I'm willing to take that. But generally, the occasional fresh grapefruit is not going to have the same effect, so that's not an issue. All right? Sales of grapefruit suddenly go up. And just to mention, while we're on the statins front, that there are other options available to try and help lower your cholesterol. So if for whatever reason you can't take a statin, or you're on the maximum dose of statin and your cholesterol still isn't low enough, it may be that they also suggest you go onto one of these tablets called a fibrate, so fenofibrate or bezafibrate are a couple of examples. And these are an alternative to statins, but they're not as effective. So we talked about statins getting 20% or 30% reduction. You're not going to get the same sort of reduction with these, which is why it's better to try and reduce the dose of statin rather than stop it completely, if at all possible. So these do decrease the total cholesterol, and the LDL and the TG, the triglycerides, which are the bad cholesterols, but still have the side effects of the muscle pain, potentially. Yeah? But you may be lucky and not get them on fibrates, even if you've got them on statins. So it's worth a try. And failing that, there is also something called ezetimibe, or ezitrol, which can be used again either on its own if you can't take statins, or in combination with a statin to try and get your cholesterol down a bit lower. And these decrease the absorption of cholesterol in the intestines, so it interferes with your intestines absorbing cholesterol from the food that you've eaten. And so, unsurprisingly, the side effects tend to be abdominal pain, because it's interfering with what your tummy's up to there, and diarrhea as well. Okay, doesn't mean you're going to get it, but those are the commonly reported side effects. So it's just a note to mention that if statins are not the thing for you for whatever reason, there are alternatives. But if you can stick with the statins, or try different statins, or try reducing the dose of statin rather than stopping it, that would obviously be the better thing. Any questions on statins at all? No? Okay, again, we're on the home stretch now then. So that's the big four groups. Nitrates I'll just mention, because this is what's in the spray. So remember we were talking about if you get angina, you're going to spray under your tongue and all that. That's what's in your spray. It's GTN spray, glycerol trinitrate spray. There are also a couple of other tablet versions of the spray. So if you were getting angina quite regularly and needing to stop and use your spray quite regularly, it may be that the doctors decide to give you a tablet version of what's in the spray that's a bit more sort of slow acting over the whole day, so that you don't have to keep stopping and spraying and then carry on and then stop and spray again. These will give you a sort of a slow acting version of it throughout the day. So ISMN stands for isosorbide mononitrate, or isosorbide dinitrate. So again, the key thing is the nitrate bit at the end. So all of these make the blood vessels relax and open wider. So the little muscles that are in the walls of the artery relax, and that makes the blood vessel widen, which means more blood can get through it. So therefore they increase the amount of blood, of oxygen, that can get to the heart through the coronary arteries. So they are used to prevent or relieve chest pain and other angina symptoms, and can also be used for them patients who have heart failure as well, because if you increase the amount of blood getting to the heart muscle, you increase the effectiveness of the pumping action of the heart too. So just to confuse further, so the GTM we've talked about is a short-acting version of nitrate. So you squirt it under your tongue, and very quickly it has its action, which is why you only give it 5 minutes to see if your angina pain has gone away, because it's that quick. There are also longer acting versions, which we've talked about, those tablets that I said you might be given one in the morning and it lasts all day to stop you keep needing to stop and use your spray. Very occasionally, you might be given a tablet version of the GTN spray as well. Has anybody got that? I know we've got one patient with it at the moment. This is usually just if you've had a bad reaction to the GTN spray. So you remember I mentioned that it lowers your blood pressure, and it can also give you a bit of a headache as well, because you get a rush of blood to your head when all the blood vessels open and you get extra blood flow. One of the downsides of that is you can get a bit of a headache. So if you have a really bad reaction to the spray, then they can give you a tablet version of it, and you just put the tablet under your tongue, and then as soon as your symptoms have gone, you spit out the rest of the tablet. So you are in effect only giving yourself a partial dose of it, instead of with the spray, you've obviously got no choice, you have the whole lot. Not very common, not that many patients have them, but just to know that it's there. Is anybody on these long-acting nitrates, isosorbide mononitrate, dinitrate? Yeah? Next slide is just to make sure that if you are taking them, you have a nitrate-free period. So if you are, do you take them once a day or twice a day?
Once a day, I think.
Once a day, right, you don't need to worry then. But some people have them twice a day, and if they do, they have to stagger when they take them so that there is a period of time where there is no nitrate in the body, because otherwise the body gets used to the nitrate and then it becomes ineffective. But if you only take them in the morning, you don't need to worry, because it will have worn off towards the end of the day anyway, and then your nitrate-free period will be all night. So forget that slide. So the tablet version of the spray is rare. We use it to relieve chest pain and angina. You can use it before exercise. I'll just mention that because some people carry the spray around and think, I'm only to use this in an emergency if I've got really bad symptoms. Well, no, because if you know that every time you go up and down some stairs, for example, you always get your angina pain coming on, then you can use it before you start the stairs to then stop you getting the angina when you do the stairs. So you can use it preventatively or prophylactically to stop you getting angina if you know you always get it at a certain point. And so some people that get angina during our classes will use their spray before they start the class, so that then they know they are able to get round and do a lot more exercise without any angina symptoms. And it's okay to use it in that way. All right. Do keep an eye on the expiry date. So when it comes, it's got something like 6 years life or something, which you'll sort of think, oh, well, I don't need to worry about that, and then you can't remember when it is. And it lives in your pocket, which you fiddle with or whatever, and then the next time you go and look for the expiry date, and you've thrown the box away, so nobody knows when it expires, and then you don't know when to get a new one. So make sure that you know what your expiry date is, write it on the calendar or something like that, so that if it gets rubbed off or you throw the box away, you still know when you've got to get a new one. If you can't find an expiry date because it has rubbed off, then get a new one and start again. As the last thing you need is to carry this thing around every single day, never ever need it for years and years and years, and then the one day you do need it, it's expired, which means it won't do what it's supposed to do. And because it is considered an emergency drug, you can actually buy it from pharmacy without a prescription. So if you go on holiday and you forget yours, or you've lost it, or whatever, you can just stroll into a pharmacy and buy one over the counter without a prescription. Okay, obviously the pharmacist will ask you some questions about what you want it for, but hopefully you'll be able to explain that, all right? Okay. Cool. Right, the next bunch of drugs, if nobody's on them, I won't go through them. All right? So, is anybody on Nicorandil? No? This will be a yes, surely. Anyone on a water tablet, a diuretic? Yeah. So you remember when we talked about heart failure, one of the things that the body tries to do is shunt some of the fluid, some of the water out of the bloodstream and hide it in some spaces like your ankles and your chest. So water tablets help to get rid of some of that excess water to stop you getting fluid retention. So things like furosemide, dendroflumetazide, bumetanide are examples. There are others as well. But the idea of them is that you take them in the morning or at lunchtime, but not at night, unless you want to spend your entire evening on the toilet. So morning and lunchtime, yes. And then you should notice when you've taken them that you do go for a wee a bit more than you would do otherwise. And what's happening is they are helping the kidney to decide to get rid of a bit more fluid in your wee, which then means there's less fluid wandering around the bloodstream for the heart to have to pump. So it's a kind of way of making the heart work less hard. Alright? And that should then improve symptoms like swelling in the ankles and the shortness of breath that you get if it was collecting in your lungs as well. But it can cause reduced blood pressure, so it's another tablet that can cause reduced blood pressure, but you can keep an eye on that and monitor it. Hopefully it won't. And it can cause gout. So if you do get gout and you're on a diuretic tablet, they'll probably give you another tablet called allopurinol to get rid of the gout. Alright? Not everybody gets gout with it, I have to say, but if you do, what they'll probably do is keep you on the diuretic if you need it and start allopurinol to help with the gout. Alright? There's also a couple of others that work in a slightly different way but still basically the same thing, spironolactone and eplerenone. Anybody on those at all? No? More of the same really, slightly different way of working. Anybody on amlodipine or diltiazem? Yes? Okay, so calcium channel blockers is the name of the group of this bunch of tablets, and they work on the muscle cells in your heart and in your blood vessels, which use calcium to make them contract. So the idea of blocking the calcium in there is to make them relax. So these tablets help the muscles in the arteries relax, a bit like we've been saying with the GTN, same sort of thing, but it widens the arteries to allow more blood to get through and also to help lower your blood pressure. So calcium channel blockers reduce the amount of calcium the muscle takes in, which has the effect of relaxing your arteries and increasing the blood supply to your heart. It can be used as an alternative to beta blockers, so sometimes if people can't take bisoprolol for whatever reason, they might put you on this instead, to sort of make up for it. So it will be given to patients who need to have angina or high blood pressure treated. And the one with this one, the strange side effect with this one, is swollen ankles. So some people get swollen ankles because of this. So if you do, and it's that bad, they might have to stop it and think of something else. And the other side effects are flushing, which means making your face go a bit red, again because we're widening the arteries, bringing more blood flow. It can make you feel look a bit red in the face. A headache because of the rush of blood to the head. A bit of dizziness if we've made the blood pressure go down a bit too low, like we've been saying with the other tablets. And the swollen ankles is the one just unique to diltiazem. Anyone on doxazosine? No? Amiodarone? No? Digoxin? No? Warfarin?
No.
No? Not got anybody on warfarin? Wow, that's fun.
They changed it to something else.
Have they changed it to one of them? A NOAC, a Pixivan, Rivaroxaban?
That's
Yeah.
it, like it.
So that's in this family.
Yeah.
So a lot of people that would have been put on warfarin previously may now be offered one of these, which is a NOAC, a non-vitamin K oral anticoagulant, which is a catchy title, which is why we call it NOACs, because it's a lot easier to say. So there are three that we mainly use in this area: Pixivan, Rivaroxaban, and dabigatran. And they have been licensed, they're quite new kids on the block really, but they've been licensed for, do you remember I said if people have atrial fibrillation, they are at risk of a stroke because the heart isn't beating and squeezing properly, so blood pools and hangs around a bit too long, which can cause a clot, which might then cause a stroke. So instead of offering you warfarin, which has the added excitement of regular trips to the blood test department to have it tested all the time, with NOACs you don't need to do that. So these are the new kids on the block, and if it's possible to switch you from warfarin to NOAC, then it's sort of something that is happening quite a bit now. Side effect again, because it's a blood thinning drug, is bleeding, so the bruising that you get will probably be even more if you're on this as well. But the big advantage is that you don't need your INR monitored, which is the thing that they test when you go for a blood test and you're on warfarin. So you haven't got all that traipsing backwards and forwards to the biology department to have your blood tested every week or month or whatever it is. Okay. All right. I'm going to skip that because it's not really relevant. So, hopefully by now, because I'm drumming it in so many times, you've realised why you're taking the pills. So many of the medicines you are prescribed are not being given to you to make you feel better or to relieve symptoms. Quite a lot of them are just being given to you because we want to make it less likely that you develop problems in the future. So it's all about prevention. Yeah? Yes, they might also reduce your blood pressure or reduce your cholesterol, but we still give them to people whose cholesterol and blood pressure is okay. And that's because of this reduction in risk. Okay, and that is applying to ones that lower your blood pressure, lower your blood cholesterol, and slow your blood clotting. So it's important that you take them, and it's important that if you get side effects, you go and talk to somebody about it. Please don't just stop them, because when you stop them, you stop all that benefit. We understand that there are side effects, and you might need to fiddle and twiddle around with the doses, you might need to look at a different drug in the same family or whatever, something that suits you better. But please don't just stop them and don't tell anybody, because you put yourself at risk by doing that. Just general medicine advice, she mentions to say, do read the instructions that come in the little box, because it does matter sometimes whether you take something with food, after food, before food, and you won't know that if you haven't read the information. Some tablets, it matters whether you can have alcohol with it or not, or whatever, and again, you won't know if you haven't read the box. Do check on storage and expiry dates. So the expiry dates goes for tablets as well, not just your GTN spray. And some tablets will say that they need to be stored in a particular place, so somewhere dark or somewhere cool. Some things have to go in the fridge, not the ones that we've been talking about today, but some other medications do. Try and keep the original containers as well, so that if you are brought into hospital, you can bring that with you, and then we know exactly what you're on and what manufacturers and all the rest of it, which type of drugs you've been taking. So we've got more information. And do bring everything into hospital, not just the regular tablets that you use, but anything else you take on a regular basis, like eye drops, inhalers, anything over the counter that you take on a regular basis, just in case that becomes relevant too. There's a little thing on there about beware of over-the-counter medications and herbal products. Just make sure that you double-check with the pharmacist, that you give them a list of what you're on already, and make sure that that doesn't interfere with it. So as I mentioned earlier, things like flu remedies and cold remedies, you have to check that they haven't got aspirin in already, because you're already taking 75 milligrams of aspirin, you don't need to take something else with aspirin in as well. So double-check with the pharmacist before you buy anything over the counter. And the other thing she's mentioned here is a medicines record card, which looks like that, which is over there on the table for you to take if you wanted to. Most people that have been in hospital, hopefully, will have seen a pharmacist, and they fill it all out, what drug you're on, what dose you're on, when to take it, what you're taking it for. So it just basically tells you, it's like an idiot's guide to what your pills are and what you should be doing with them. If you haven't got one of them, you can either just help yourself and do your own one, or your local pharmacy do these things called medicine use reviews or a prescription MOT. So one of your pharmacists, your local pharmacist, will sit down and fill it in with you as well if you want to. If you have any troublesome side effects, to ask your doctor to just stop them. And always consult with your doctor before stopping a medicine or changing your dose. Any questions? You're all stunned into silence. Yes?
I've been asked to have a blood test, or I've had the blood test.
Yeah.
How do I know what they've tested? Because you've mentioned things there that should be tested.
You don't, unless you ask.
Right, so therefore I have no idea about the liver thing, right?
Yeah.
Or the kidney thing.
Kidney
So
thing. Yeah.
have
Kidney.
they tested it or haven't they tested it?
Well, they probably have, but I don't know.
Well, so how do I find that out then?
Ask them.
Ask for a printout.
Ask them. Yeah, you can get a printout, but it probably won't make it much sense to most people.
I've only met my GP once in 50 years, so I don't know.
Well, you can ring up the surgery and ask
You
to
get
speak
told,
to
I asked
somebody.
about the cholesterol, but you don't get told about other stuff.
Right,
You can ask
you have to ask.
for a report of your blood results. Anybody can have those, especially
Yeah.
if you're with your...
They can give you a printout, and then if you don't understand what it says, bring it in to us and we'll decipher it for you. But they usually do, U's and E's is the abbreviated version for kidney function, which is urea and electrolytes.
Yeah.
So they usually will test that with most blood
Okay.
tests they do. But the other one is liver function. So if you're on a statin, they should also be checking your liver function. And they might not do that 2 weeks after you start it, but they should have done it at least by 3 months. And then that's another thing that annually they should check your liver function as well. And some of the other tablets have other things that need to be checked as well. But the only way you know, because all you know is you gave an armful of blood and then it disappeared off somewhere, you don't really know what they've checked it for. But you can ask for the printout, and then if you don't understand it, either make an appointment to see your GP and go through it, or bring it into us and we'll try and help.
Hayley, they often do fasting glucose as well, don't they, in the same
fasting.
test?
Well, sometimes, yeah, you'll know if you fasted for the blood test, won't you? So most people, if they're having a fasting test, know whether it's because of glucose or cholesterol.
Mm.